Welcome to AETCM, the emergency medicine channel. As part of EM Rapid, now we are discussing stroke management in emergency room. I will not be going into the details of the various types of stroke. We'll be discussing how to manage a stroke in emergency. Stroke or cerebrovascular accident is defined as an abrupt onset of neurological deficit, and it is due to a focal vascular occlusion or a bleed. Both can produce stroke. We see the causes of stroke. There are two important types of stroke. One is ischemic stroke, that is 85% of the strokes are due to ischemia, whether it is due to embolism, it can be from heart or any other arteries, thrombosis in a major artery, or hemorrhagic strokes. The number of hemorrhagic strokes are not very common. The commonest stroke is always ischemic stroke. In that, embolic strokes are predominant because embolism can occur from a thrombus. Thrombus can lead to embolic, or a heart disease can produce embolism. There are a lot of other conditions which can present as stroke in emergency room, mimicking a stroke. Syncope can present as a stroke, but more normally after syncope, patient recovers within few seconds. Hypoglycemia can present as stroke. Sometimes hyperglycemia also can present as stroke because hyperglycemic comas are very common. Migraine, especially complicated migraine, can present as stroke. Seizure with Todd's paralysis can present as stroke. Demyelinative disorders can present as stroke. Encephalitis also can present as stroke. So these are the common differential diagnosis for stroke in emergency. Now, ischemic stroke can be divided into embolism or thrombotic. Thrombus can form inside a major artery, and it can produce stenosis in that artery, and it can also involve the small arteries in the brain. Sometimes this thrombus can produce embolism into the cerebral circulation and produce embolic stroke. Embolic stroke, it has got two major origins. One is an arterial source. Atherosclerosis plaque can dislodge from there and produce an embolism, or from heart, like atrial fibrillation or large thrombus in the ventricle due to cardiac failure. So many conditions can produce cardioembolism. Mostly these embolic strokes present as a sudden onset of weakness, whereas thrombotic stroke slightly it takes time because slowly it may progress. The propagation of thrombus may take some time, but embolic stroke occurs all of a sudden, and the recovery also very fast in embolic stroke because autolysis of the thrombus can occur in our body. So embolic strokes can be two types, from the arterial source or from the cardiac source. Cardiac embolism, most common cause for cardiac embolism in our practice is atrial fibrillation. Atrial fibrillation can be due to mitral stenosis, mitral regurgitation, or prosthetic valve, endocarditis type thrombi, dilated cardiomyopathy. So many things can present with embolic stroke. Hemorrhagic stroke, we have seen only 15% of the strokes are due to hemorrhages. In that, it can be divided into subarachnoid hemorrhage or ICH. In ICH, most of the bleeds are due to hypertension. Hypertensive bleed is most common in intracranial bleed. Subarachnoid hemorrhage, it is mainly due to aneurysm or AV malformation. Again, both ICH and SH can be due to all these causes, but the most common cause for ICH is hypertension. Most common cause for SH is aneurysm. ICH causes, we'll see. The most common site of ICH bleed is putamen. Most common site putamen is with basal ganglia, thalamus, caudate nucleus, pons, all these areas we can get. Common site for aneurysms are anterior circulation, anterior communicating artery at the bifurcation of MCA from ICA, origin of PCA from ICA, posterior circulation at the apex of basilar artery at the origin of PICA, and superior cerebral arteries from basilar artery. The picture you can see here. Putamen is the most common site for ICH, and aneurysm, it is anterior communicating artery. You can see from the figure. Now we can see the clinical features according to the territory: carotid artery, ipsilateral monocular blindness, contralateral hemiparesis and facial weakness, hemianesthesia, aphasia, seizures, reduced carotid pulsation with bruit, vestibular basilar territory, posterior circulation, sudden drop attacks. That is a common finding, and patient can have ataxia, dysarthria, vertigo, tinnitus, diplopia, and nystagmus. So posterior circulation findings are predominant in vertebrovascular artery, and carotid artery anterior circulation features are common. The most common type of stroke what we see in our clinical practice will be carotid territory type of weakness. It can be in the ACA or MCA. Hemorrhagic strokes, they present as acute severe drop in GCS, vomiting, seizures, papilledema, severe headache. Patient can have neck stiffness in subarachnoid hemorrhage. Blood in CSF can be there. Normally we don't do LP in subarachnoid hemorrhage, but previously when we didn't have so much imaging facilities, we used to do CSF. That we can see blood in CSF. Cranial nerve involvements are common in case of compression by aneurysms. The prognosis of hemorrhagic stroke, if in general, supratentorial hematomas with volume less than 30 ml have a good prognosis. 30 to 60 ml have intermediate prognosis, and more than 60 ml have poor prognosis. Intraventricular extension location within the posterior fossa, because that's a small area. Posterior fossa is a small area, small compressed area. In that bleed occurs means patient will deteriorate very fast. Depressed level of consciousness at initial presentation, all are bad prognosis. Even advanced age is also bad prognosis. Now we have a scoring system for it's mainly a UK based scoring system, National Institute of Health Stroke Scale, NIHSS. According to that, we can score the patient's clinical scenario. I have given the link for this calculator, score calculator. Score 0, no stroke symptoms. 1 to 4, minor stroke. 5 to 15, moderate stroke. 16 to 20, moderate to severe stroke. 21 to 42, severe stroke. Now, whenever we come across a stroke or stroke mimicker in emergency room, we always do some basic investigation before treating the patient. The most important investigation in emergency room, any type of coma, including stroke, is blood sugar. Both hypoglycemia and hyperglycemia can present as stroke. Hypoglycemia mainly present with acute onset of weakness, loss of consciousness, seizures, sweating, all these things. Hyperglycemia can also present as coma. They are called as diabetic ketoacidosis or hyperosmolar coma. Both conditions, patient can have stroke-like features. So blood sugar is most important. Then we see sodium levels, calcium levels, urea, because renal failure with high urea can present as uremic encephalopathy. Then we do infection screens. These all go simultaneously along with the stroke investigation and management. But the most important test you should remember is blood sugar value. That should be done as a glucometer blood test. Now we can ask for a prothrombin time because patients who is on warfarin, patient who is having liver disease, patient is having chronic blood coagulation disorders have elevation in prothrombin time and activated partial thromboplastin time. So that should be done. Additional tests like toxicological screen can be done because some patients who is having uh, substance abuse can present with stroke-like features. Fasting lipid profile, ESR or CRP, because in arthritis you can get elevated CRP or ESR. Pregnancy test. In suspected hypercoagulable state like stroke in young, you'd ask protein C, protein S, antithrombin 3, factor V laden, antinuclear antibodies, dsDNA, VDRL, homocysteine level, anticardial lipid antibodies. So many investigation can be done in patient who is having stroke in young age. Lumbar puncture previously we used to do. Nowadays we don't routinely do it. But patient who is having meningitis, suspected meningitis, and vascular involvement, vasculitis due to meningitis, sometimes and they present with stroke, stroke-like feature. In that type of patients, we recommend uh, lumbar puncture. Otherwise, routine cases of stroke, we don't do lumbar puncture. CT scan, what we should understand is in emergency room, we have to rule out a bleed before treating this patient. If the patient comes in window period, that means if we can thrombolize the patient, we need to rule out bleed. So non-contrast CT is the most important investigation which can detect hemorrhage in the brain. So if there is no hemorrhage, we can go ahead with the management of stroke with tissue plasminogen activator. Uh, Normally, it will not pick up, the initial scans will not pick up any ischemic area in the brain unless it is a large and there is tissue damage, brain edema. We won't be able to see it with a normal non-contrast CT, but CT is required to rule out bleed. Posterior fossa infarcts also, it is difficult to pick up by CT scan. So CT scan is not a good investigation to rule out ischemic stroke, but it's a very good investigation to rule out hemorrhages before thrombolizing the patient. You can see here CT showing acute left middle cerebral artery infarct with mild mass effect. So we can easily pick up the mass effect in that CT scan. Acute infarction in MRI, but it can pick it up very fast. But comparing to CT, it is better. You can pick up it in a better way. So if you have a patient who is coming after the golden hours, like we cannot thrombolize the patient, then no need to go for CT scan. There we have to go for MRI scan so that you can pick up the lesion better, and MR angiogram also can be done there itself. So CT will pick up the hemorrhage, MRI will pick up the infarct. But in acute cases, when we want to thrombolize, we cannot waste our time because MRI takes minimum 20 to 40 minutes. CT takes hardly 5 minutes. So if the patient come in the golden hours where we can thrombolize the patient, we should not waste our time. We should send the patient for CT scan, and once the CT rules out hemorrhage, we can thrombolize the patient. MRI, we already discussed. MRI is a very good investigation to pick up uh, ischemic stroke. We have in our hospital, we have a protocol, MRI stroke protocol, in that we do both CT scan and MRI, some sequences. CT, once it is picking up uh, uh, hemorrhage, then we will not be continuing with the other things. We will start managing the patient. And if the patient comes after the golden hours where we cannot thrombolize the patient, we routinely do MRI with MR angiogram or digital subtraction angiogram to pick up exactly where is lesion. If it's a bleed, we can pick up from which artery aneurysm it is bleeding. If you want to coil or if you want to do a procedure, it will be helpful. So MRI and MRI angiogram will be very useful to identify where exactly is the problem in the brain. But to rule out a bleed, in an acute emergency, CT will be a better choice. So, if the patient is having high blood sugar, it is better to control the blood sugar and keep the blood sugar between 140 to 180 milligram deciliter, especially in ICUs. We routinely use insulin therapy. Oral hypoglycemic agents, if it is well controlled with oral hypoglycemic agents in this range, we can continue oral hypoglycemic agents. If it is higher, it is better to put the patient on insulin. If it is very high, it is better to start him. Control of BP in ischemic stroke. We have to maintain the cerebral perfusion pressure. That is very, very important. If the patient is having high BP, if we suddenly drop the blood pressure with some sublingual tablets, there will be sudden drop in cerebral perfusion pressure, and that can kill the ischemic penumbra surrounding the stroke area. So, a cautious reduction in the BP, especially when the BP is slightly higher, that may be that high BP may be helping the perfusion of this ischemic penumbra. We have to keep the target systolic BP less than 185 and diastolic BP less than 110 before thrombolytic therapy. The blood pressure should be less than 180 105 millimeter of mercury for at least 24 hours after intravenous tissue plasminogen activation. Labetalol is the ideal choice in most of the conditions, CNS conditions. 10 milligram IV every 10 minutes can be given. Or we can give infusion 2 milligram per minute. And recommendation is to lower the mean arterial pressure to less than 130 millimeter. In hemorrhagic stroke, we need to have a little rapid control of BP. For patients with acute bleed with systolic BP 180 to 200 milligram, acute lowering of systolic BP to 140 is recommended. Here also we use labetalol, and here also we can we can see the target mean arterial pressure should be targeted less than 130. The IV labetalol is again used here. So rapid correction is recommended in hemorrhagic stroke than in ischemic stroke, because most of the time the bleed is due to high BP, whether there is aneurysms are there or not. Most of the patients will have high BP. BP has to be controlled. If BP is not getting controlled, there is a further chance of bleed. Whereas in ischemic stroke, mostly the high BP is due to the body's mechanism to make the cerebral perfusion pressure in the range to keep the perfusion of ischemic penumbra properly. Nimodipine can be used in subarachnoid hemorrhage, 60 milligram fourth hourly. It delayed SH delayed cerebral ischemia as a result of cerebral vasospasm can occur. This can reduce this drug can reduce the vasospasm. Nimodipine is a calcium channel blocker. It acts in the brain. It reduces the vasospasm. Like other calcium channel blockers reduce the vasospasm in the heart or peripheral circulation. Nimodipine reduces the vasospasm in the cerebral circulation. Now, if the patient comes in less than 4 hours in emergency room with a stroke, ischemic stroke, we are doing a CT scan which is normal, that means there is no hemorrhage, then we can give this patient with a thrombolytic therapy, that is tissue plasminogen activator. Door to needle time has to be less than 60 minutes. Do a non-contrast CT within 20 minutes to rule out bleed. Then start TPA 0.9 milligram per kg intravenously. Maximum is 90 milligram IV. 10% of the total dose by bolus in 1 to 2 minutes, followed by remainder of the dose in less than 1 hour. So tissue plasminogen activator should be given after a non-contrast CT, which rules out an infection. The door to needle time has to be less than 60 minutes. We are going for an MRI, it will become the MRI itself will take nearly 45 minutes. So we don't do MRI before thrombolysis. It is not a recommendation. MRI is not a standard recommendation in stroke. TPA indication age more than 18 years, clinical diagnosis of ischemic stroke, onset less than 4.5 hours, non-contrast CT showing no hemorrhage. These are the indications. Contraindications are, there are a lot of contraindications like BP more than 185 to 110, platelets less than 1 lakh, hematocrit less than 25%, blood sugars are very high or very low, heparin used in last 48 hours, rapidly improving symptoms without any treatment, prior stroke. Like there are so many contraindications also. Now, most of these patients who is having large bleed or severe ischemic uh, stroke, they can have mass effect in the brain, raised ICP can be there. So head end should be slightly elevated, 30-degree elevation can be there. Hyperventilation can be tried in this type of patients. Put the patient on ventilator, mechanical ventilation, and uh, hyperventilation can be tried in the mechanical ventilation. PaCO2 goal of more than 30 to 35 millimeter of mercury is suggested here. Mannitol can be tried in this type of patients where there is large thrombus or large area of stroke with mass effect. It can be tried initially. Hypertonic saline is another way to reduce the raise the ICP. Give 3% saline at an infusion rate to maintain serum sodium level 145 to 155 milliequivalents per liter. Now, complete sedation with propofol also can be tried. 1 to 3 milligram per kg can be tried. So these are the things we should do in emergency room to reduce the uh, effort of the patient. Like patient should be completely sedated. Patient should not have any fever. Patient should not have any hyperglycemia. All these things should be taken care. In ICU, we have to take care a lot of other things like patient should not develop bed sores. Patient should not have urinary tract infections. Patient should not develop aspiration. So many precautions also taken should be taken in emergency room in stroke management. We have discussed about emergency management of stroke, especially in emergency room and emergency ICU. A detailed evaluation and investigation may be required in some patients. Other procedures like stent placement, coiling, all these things can be tried afterwards. Thank you.